Hello, everybody. I'm Eduardo Albéniz from Spain. I work in the University Hospital of Pamplona, Navarra. And to me, it's a great pleasure to be here to moderate this ESGE webinar. Thank you for the invitation. Today, our topic is prevention of delayed bleeding after EMR. It's one of my preferred topics. I did my PhD in this topic. And this afternoon, we have the real pleasure to have two big names in the endoscopy field, two professors. And we start with Professor Heiko Pohl. He's a professor of medicine in the School of Medicine in New Hampshire, a director of endoscopy in the VA Medical Center in Vermont. So we start with the presentation of Heiko. Please start when you consider Heiko. Sure that we have a lot of questions about your talk.
Well, Eduardo, thank you very much, and thanks to the ESGE organizers to invite me. Always a pleasure to be part of this conversation, and also nice to kind of see you guys in person. So, as to you, it's also one of my favorite topics, and so let's talk about prevention of delayed bleeding after EMR, and I'm going to focus on using clips for bleeding prevention. So here are my conflicts of interest. So I'm going to try first to update ourselves on the data that have been more or less, well, first on the original data, but then also on the most recent data to understand where we stand with evidence that supports or does not support using clipping or clip closure for bleeding prevention. And then I want to highlight the challenges related to clipping and then also provide an outline what's next. So I always like to go back to history, and I found it interesting and fascinating. The first clips actually were not much later developed or invented after the first snares were invented in 1971. First clip in 1975 by Hayashi, published in Gastroenterological Endoscopy. At the time, the clip was used for bleeding treatment. So there was no thought of bleeding prevention. And it took more than 20 years or so before the first studies looked at the idea of using clips for bleeding prevention by closing the defect after resection. And if we think about defects in the intestinal tract, you can have defects from the esophagus to the colon. And all areas have different risks of post-procedural bleeding or post-resection bleeding, which is highest in the duodenum. And then, of course, there might be a different risk between EMR resection, ESD resection, or other types of resection that I'm not going to talk much about. But the idea is that most studies really looked at EMR and resection in the colon. So where we have had a baseline risk of 5 to 10% after resection of large non-pedunculated colorectal polyps. And large meaning 20 millimeters or larger. So if you talk about clip closure, so what defines complete clip closure? And one of the first definitions that were used by Doug Rex is to have clips not more than 1 centimeter apart and have no or minimal remaining visible submucosal tissue. So as you can see here, the other thing is also the question whether you're going to close or clip the submucosal area as well, or whether it's sufficient to close the mucosa just over the submucosa. In general, we think the vessels are deep within the submucosa, and we want to kind of have an effect on those deeper blood vessels to prevent bleeding. So the first study really published on the idea that clip closing could prevent bleeding was published more than 20 years ago, and it did not show a difference, 1% in both arms, and this includes almost all polyps. And then there were subsequent studies. They were summarized, of course, as always, in the meta-analysis, and there was no benefit for the general approach to using clip to prevent bleeding after any polyp resection. But then in 2013, Doug Rex and first author Lacquette, they looked at their data since they started clip closing those large non-pedunculated colorectal polyps, 20 millimeters or larger, and compared them to historical controls. And they found a major difference, about 2% after they started using clips compared to almost 10% in the historical controls. And that sparked an interest into randomized studies. And in 2015, there was a study from China, actually the first one, that was the first randomized study. They found a difference between 7 and 1%, or of 7 and 1%, but they included all polyps 10 millimeter or larger, and include different ways of resecting the polyp. And then in 2019, there was this is like the year of clip closer study publications, together with Eduardo, and another VA study, Fegans. 3 large studies were published on that topic. And as you can see, Eduardo's study showed a major difference, 12 to 5% reduction with clip closure. In our study, the reduction was 7 to 3.5% by 50%. And the Fegan study included 10 millimeter or larger polyps. There was no reduction. And if you look at the about 200 polyps, total polyps were about 1,000, there was also no reduction in clip closure of the, very fewer large polyps in that study. But if we look at, and there are differences in the risk factors among those studies, so it's not surprising that Eduardo's study had a greater reduction because the baseline risk was greater. But what we did in our study, we wanted to find out, is there a subset of polyps that had a greater benefit than others? And we found that really the effect was focused only on proximal polyps and not distal. So we didn't see a protective effect of clip closure for distal polyp. If anything, there was a numerical increase among patients who had clip closure in the distal colon, meaning splenic flexure to the rectum. And there was about a reduction by 66% or by 2/3 in the proximal colon. So it seems like clip closure was beneficial only for proximal polyps. And then there was this follow-up study a couple of years later published by the Australian group, Michael Burke. They only included proximal polyps, and they found almost an identical reduction in baseline risk in no clip group versus clip group for all proximal polyps. And of course, as always, as I said before, this was followed by a meta-analysis. And again, all size polyps, no reduction in bleeding. Polyps greater than 20 millimeters, there was about a 50% reduction in bleeding. And by location, no significant reduction for distal polyp, for large polyps, but a significant reduction for proximal polyps. That seemed to seal it. That's the biggest evidence. We had randomized trials, 3 randomized trials that showed a positive effect. The smaller sub-analysis of the Fegan study did not show an effect. And we actually did another sub-analysis of our clip data and found that there seemed to be, above all, the effect related to adenomas. There was no significant effect related to cell ulcerated lesions, although the numbers get small. And if you look, relative risk reduction would also be 50%. But it seems like among the adenoma polyps, the risk reduction was greater than among the cell ulcerated polyps. So again, here, the meta-analysis, altogether, those studies suggest you should clip defects in the proximal colon after polyp resection of 20 millimeters or larger polyps, and not in the distal colon. Now, this is the most recent study from Holland that actually did not confirm those prior studies. They only enrolled patients with, or they enrolled patients with proximal polyps 20 millimeters or larger, and a pretty good number. And they did not find a risk reduction, numerically actually an increase. So the clip group 9% post-posterior bleeding risk, and the non-clip group 6%. I don't think that paper is published in full yet. I think this was, so far I looked for it. It was an abstract presentation last year at UEGW. But that really kind of highlights that, it's not always the case that clips reduce bleeding, and it's unclear why it didn't work here. Actually, the closure rate among those large polyps was similar to our other studies. You might say maybe they didn't close it enough. Maybe they had a different definition or application of complete clip closure. Maybe they didn't go deep enough in the submucosa. But there's definitely not a unanimous benefit among all the studies. And then another study also did not find a benefit, which is more or less a pragmatic study that used retrospective data from Canada, almost, I think, more than 8,000 procedures, looking at the benefit of clip closure in the propensity score matched method or analysis. And overall, you see anything clip closure, there seemed to be an increased risk of bleeding, but it was not significant. So here you might say among the 20 millimeter polyp, well, 3.4% overall risk is pretty low, and maybe there was no signal to further reduce that already low risk of bleeding. But again, the prior Dutch study had a pretty high baseline bleeding risk, which other studies had too, and they did not see a reduction in bleeding risk either. So, well, there is still strong evidence, and I bet the future meta-analysis that includes the Dutch study will still show a benefit for proximal lesions. It's not as unanimous or shown by all studies that looked at that. Okay, so now that gets us to the question that I hear often: what shall we do with the patients who have, let's say, who are on antithrombotics and have a distal large polyp? Wouldn't you clip that study? Or what shall we do with sessile serrated lesions? And so, so there might be high risk distal lesions, and then there might be low risk proximal lesions that we shouldn't close. So the way to kind of get at that idea is prediction tools. And again, Eduardo did a lot of work on this, creating two generations of prediction scores. In addition to the Australian group, they also had the ESGE score, and this score is from Eduardo's group. And they found a moderate prediction to predict post-posterior bleeding using several factors. And some of them are the same, like proximal location, size, comorbidities, and also antiplatelet use, anticoagulation use, or epinephrine use or not use. We tried to look at this in our CLIP cohort, and we could not reproduce that prediction tool. So we did not have any predictive effect of this tool in our study. So kind of, I'm not so convinced that this prediction tool is really very practical, but we might move on to something else, namely to something AI related. And I found this small study really intriguing. This has been published now in 2020 in Endoscopy by the Australian group again, and they used characteristics of the resection defect, like the blood vessels, and put this into a computer program, network program, and they found a sensitivity of 100%, which is extraordinary in their small data set. So I think this is hypothesis generating. It's interesting, and I hope there will be future studies on this that might help us to make decisions on what lesions to close or not. All right, what are the challenges with clip closure? Well, one of the challenges is really incomplete closure. The other one is cost. Let's talk about the incomplete closure. And here we created this graph, which I think is interesting because we looked at about what's the rate of clip closure by size. So increasing size, inability to close. And this is our closure rate of all polyps that were in a 20 millimeters or larger study. 68% were completely closed. And as I said before, in Eduardo's study, the risk profile of the polyps of patients was greater, and they, on average, had a greater size of the polyps. But it's interesting, it really falls on the same line. We have 57% of complete clip closure. And the study by the Dutch study had 71 complete clip closure, and they are, I think, at 30 millimeters. So they would also fall on this line. Kind of try to understand, are there any modifiable factors on there that we can do to improve clip closure? And there's really not much. There's the size, you can't really affect size. There's the non-lifting sign, can't do anything about that. If you have an adenoma, it seems like it is associated with, I think, less of a closure. So an SSL actually should have a higher risk of clip closure, higher odds to clip close. But access, so you can do something about access. And what can you do? You can reposition the patient. So if you have poor access and you want to try to improve access, see if repositioning the patient helps. But perhaps more promising are the technological advantages over the past couple of years. We have all read probably or come across all different kinds of variations in using loops and rings to approximate the margin, or suture supported, which is also very intriguing, which I don't have here. So this is still being practiced primarily in Asian countries, but on the development of the clips and other suturing system, there has been some improvement. And I just want to highlight 3 of those advancements, which I think are key. So the first one is actually a dual action tissue closure clip. The next one is an anchor prongs clip, and the third one is an through the scope suturing system. So here we have this dual action tissue clip. I would call it, or in my mind, I call it like a twin clip, which you have 2 handles, each handle closes one side of the clip, and you could see that you open up just one side first. It's similar to the Wesco twin grasper. So you grab one, you close it, you drag it over to the other side, you open the other side, you close it, and then you fire it. So I think a very smart device. I have to admit, I have not been able to get my hands on it and use it. But from what I hear, the rotation is not an option really, and they are pretty big. So you might be compromised by the flexibility and the size and how much room you have to manipulate this. But this was the first study just published by Dennis Young and his group earlier this year, with complete closure using the dual action clip. And 96%, so almost all, which is of course much bigger than 66% or 70%. And there were no associated bleeding. Let's hold this for a moment. The time was 7 minutes, which is totally reasonable, which is like similar to complete clip closure with clips, maybe even faster. On average or a median, they used one of these clips and completed the closure with a median 2 additional clips. And you see the size was actually pretty large, 4 centimeters. They included, by the way, EMR and ESD defects. That's a mistake. And interestingly, in about 100 patients, you would in general expect a bleeding rate of about 5%. Maybe if you have clip closure, 3%. They only observed 1 patient with bleeding, which seems to be on the very low side. So for sure, arguing that this is really working well. So here is the other new clip, the anchoring clip. So you grab it, it still has 2 prongs, but the tip of the anchor is so sharp that it kind of gets into the mucosa and stays there. So you open up your clip, you go into one side there, you go and you close it, and you drag it over to the other side, and then you open it up again, and it doesn't slip, and then you open it and close it from there. So I have used this. I like it. You can manipulate it easily. It's not as rotatable as other clips, but it's working to really approximate the margin of deep defects. So it seems to be a good working clip to close large defects. And here you can see there is one study that was just published 23 here last year, surgical endoscopy, the overall closure rate with the anchoring clip was 98%. So similar, you could close like almost all lesions with this. But you see the mean size is pretty low, so included much smaller lesions. And then when they used in the standard clip group, they could only close 71%, but they could complete the clip closure to almost all when they added the anchoring clip. So pretty promising, either of those clips. So the third new thing on the horizon, it's been around for 2 years, is the through the scope suturing system. I don't know if it's available in Europe, but so I have used this now for probably 1.5 years. I really like it. So the smart idea is you have something like screws that you drill into the mucosa and that are connected via a suture. And so you go like in an N pattern or a Z pattern. And then once you have deployed all the 4 preloaded screws or helixes into the mucosa, you tighten the suture and you cinch it down. So, so I think that's a great thing to close defects. The only thing that it doesn't do, it doesn't close the submucosal defect. So what you do, you pull the mucosa over the defect, similar to pulling curtains over a defect. And it's not quite clear whether it really reduces the risk of bleeding. Probably it should. So, but we can talk about this. Difficulty, there was like a Porkin study where they said the difficulty similar to clip closure. I think it's a little you have a learning curve with the entire system, but once you have it like straightened out with your assistant, I think it's pretty smooth. It takes about 8 minutes to set one of those 4-prong systems, 4 helix systems. So here's the 2 studies, one on ESG colorectal defect, one on EMR colorectal defect. There are other studies that also use it for fistula closure or mixed patient population. But in general, those 2 studies, they found if you just use the suturing system alone, 66-54%. But then if you add on the clips, you can close almost all the defects. And this study here, which was just published, had 3% delayed bleeding rate, which seems to be lower than expected for 3.5 centimeter lesions, but still on the low side, which is good. Number of systems 1, and you need additional clips about 3. In my personal practice, I think you only need 1 system to approximate the margin in a way, and the rest you just close with clips. So I'm not surprised that only 50 to 66% or so were closed completely with the suturing device, which I don't think it's really the aim. All right, 2 more aspects before I come to a close. One is the cost question. And Eduardo, as you, we have also looked at this cost question in models, and we found that really the clips should cost less than $100 to be cost effective. And then the question is, and I'm going to just jump to, and interestingly, the cost of the dual action clip, the anchor clip, and the through the scope suturing system is about 3 to 4 times the cost of standard clips. So they would replace about 4 clips. So it seems to be, I'm not sure whether it's really cost effective, but it seems like it continues to be expensive to close defects. So I think this is like an interesting consideration. Who is asking the question whether it's cost effective? Of course, you can come from an individual or a societal perspective, and then you can think about, okay, is it effective? Yeah, for proximal lesions, it's effective. For distal lesions, well, 2% absolute risk reduction, not significant. It's not really considered effective. Then from societal perspective, are we willing to pay for this as a society? And maybe should only include those with a higher bleeding risk at baseline, because then we have a better effect from the closure. And this is from Eduardo's study. But on the hospital side, we say, okay, if we clip, we actually lose money. So should we lose money if we place clips? Should we even allowed to place clips? And of course, the patient doesn't ask really all of those questions. The patient just wonders, could it help me, and at what risk and what cost? So, and finally, I want to just briefly mention that aspect. And Vicente's group, actually, they worked on this great study to calculate the carbon footprint of endoscopic instruments, snares, forceps, but also 2 hemoclips. And you can see that the hemoclip A versus hemoclip B had a lower carbon footprint than the other one, reduction by almost 30%. So it might matter what clip you use if the quality of the clip is the same. And then if you do some other calculations, you can say, if you use or if you close 1 defect with 4 clips, it adds about 2 kilograms of carbon footprint per procedure, considering that the procedure, based on a recent study from France, emits about 20, or the carbon footprint is about 28 kilograms. It adds about 7% of emissions to an endoscopy procedure, or 8 kilometers driven by a gasoline car. So with that, I come to the close. I think the evidence is still strong to use clips for closure of defects after hot EMR in the proximal colon. There have been excellent advancements in closure devices and techniques that will help us to close all defects or almost all defects. Cost remains a major concern. And I think in the future, we will have a more individualized approach to closure and resection. So based on, are patients at high risk for bleeding, antithrombotics, what's the polyp size, location, histology, morphology, what resection technique did I use, and what device do I have available? So with that, I close, and I'm looking forward to questions and discussion. Thanks.
So thank you, Heiko, for your nice presentation. We have a lot of ideas now in our minds because it's not a simple question. We have tried in the studies to simplify the solutions with 11 millimeter clips, but right now we have a rainbow of artifacts to use in hemostasis prevention. But maybe we'll leave the questions to the final. And now I wanted to introduce the next speaker is Vicente Lorenzo-Zúñiga. He's a board member of the ESGE Society, also the connection with between the Spanish Endoscopy Society and the European Society. He works in Hospital of Valencia as an interventional endoscopy. He's also professor of Universidad Católica de Valencia. Now Vicente is addressing another topic because we can close all the defects, so we need some coverage agents to prevent also delay bleeding. So Vicente, please.
Thank you, Eduardo, for your kind introduction. So good evening or good afternoon. First of all, thank you also obviously the ESGE for the invitation to participate in this webinar to talk about, for me, a very interesting topic. As Eduardo has said, I look into the use of coverage agents in the prevention of delay bleeding after EMR. These are my conflict of interest. During my presentation, I'll try to answer some questions we have about these agents to reach the state of the art with them. The first question we have, I think, is to start with the definition to define what is a coverage agent. I think we can define them as any medical device. They can be tissue or hydrogel, but most of them are hydrogels with proven bioactive properties with the objective to create a shield protection. It's evident that under this definition, all of us have identified clear indication of use, and depending on the indication, we will require different properties. Sometimes we will require a more hemostatic effect, other a more sealant activity, or just to increase the mucosal healing. And depending on the properties we need, we will select one agent instead of others. But the most important is we have to take in mind to have knowledge about the efficacy in daily practice based on published articles. The second question we have is why hydrogels? As I've said, coverage agents can be tissue or hydrogels, but hydrogels are excellent candidates for tissue engineering, wound healing, and controlled dry delivery. Why not? Because perhaps in the future, we also can deliver some drugs to treat, to provide some anti-tumoral effect in early cancer. We have also to remember that when we administer these hydrogels, we are going to use a large catheter and thin catheter through the working channel, and they should be liquid at normal temperature, and they should gelify, become more dense over the lesion. So it's important, the properties is for that these hydrogels are developed by the combination of different properties or different polymers to reach the properties we need. All of them are biodegradable, are biocompatible, they have adhesion capacity, and have to enable mechanical properties. It's evident this is a very huge research area, and we are not bioengineers. So as endoscopists, we have to have some clear ideas and to remember the coverage agents are three-dimensional structures for cell adhesion and proliferation, and that exist different cross-linking methods that can be physical or chemical for hydrogel synthesis. And secondary to these evidences, in the last year, we can observe a rising number of publications focused on the use of hydrogels, not only in GI endoscopy and in other parts of the digestive tract. Regarding the indications, in this slide, you can observe some situations we can use coverage agents. For example, in acute GI bleeding, we can use hemostatic agents, sometimes hemostatic powders or hydrogels with hemostatic effect. I think the definition, hemostatic powders, hydrogels, coverage agents is the adhesion capacity. In other situations, in GI perforation or in anastomotic leaks, we are going to require sealant properties to close the hole or the leak. Today we're going to talk about EMR, but with ESD we also have delayed adverse events, we have delayed bleeding, delayed perforation, and also late stricture. To prevent delayed bleeding after ESD, to my knowledge, there are only two agents with clinical evidence in practice, Surgicel and Purestat. Surgicel is a tissue, hemostatic tissue that can be administered topically, but is an oxidized cellulose that can be manually diluted into saline and applied with an spray catheter and to form a gelatinous mass. And in this single-center study with around 50 patients in colonic lesions around 40 millimeters, the authors found a 0% of delayed bleeding. And they explained it, the results are based in the hemostatic and also in the bactericidal effect of this agent. Purestat is another well-known agent that I'll talk in detail with in EMR, but here also has, this agent has experience in ESD. This is the first published article about the efficacy prevention of delayed bleeding with similar lesions and in the same size in colon, and the risk of bleeding is a bit high. Perhaps the explanation of these different results, we're talking about small sample size as single-arm studies, perhaps is the bactericidal effect. Perhaps we can talk more in detail after. To prevent ESD perforation and also to prevent late strictures, we can use a more time-consuming technique, is the shielding technique with polyglycolic acid sheets and glue, and then step by step, you can cover this large mucosal defect or to treat the perforation with good results in different published case series. But now we have to move to the prevention of delayed bleeding after EMR. And the next question is why we talk about coverage agents. It's evident that in the last year, the use of coverage agents has gained interest because it's the simplest and quickest method to cover large mucosal defects, also because provides a shielding protection and also accelerate the mucosal healing, and because, and Heiko is explaining it very well, complete closure is not always possible. Overall, the risk of bleeding depends on patient and lesion characteristics, so we have to focus on patient at medium and high risk of bleeding. Patient at risk of bleeding higher than 4 or 5%, but perhaps we can find difference between the expected bleeding, the observed bleeding, perhaps the technique, the accuracy, your expertise is one of the reasons of this difference. But despite this promising technique, I think this is a promising technology. Today we have a lack of randomized clinical trials and head-to-head comparative studies between different hydrogels or combination with other mechanical systems like clips. The challenge we have in the prevention of delayed bleeding are focused in patients and poly-related factors. Also, how is the procedural, how is the technique we have performed. With this, we build a score, and with this score, we have predict the risk of bleeding, and with risk of bleeding, we apply the preventive measure. Now we back to the basics. And in this slide, illustrates the physiopathology of delayed bleeding after EMR. As you know, when we perform an EMR, we create a mucosal defect, and the size and the depth of this defect with the extension of the thermal injury very close to the vessels increase the risk of bleeding. Also, the risk of bleeding increase with the trauma from the lumen content, with inherited or acquired coagulopathy, secondary to medications or different diseases, and also by the bacteria activity, because at least in colon, we create an infective gun, and the bacteria can increase the flow, the blood flow, and this can increase the risk of bleeding. And also when the lesion loses the protective scar. So, and the risk of bleeding is higher during the first 2-3 days. So under this image, it's easy to understand or make sense or seems logic that if we cover the mucosal defect with something, we are reducing the risk of bleeding. And this coverage should be maintained at least during the first 24-48 hours. It's evident that to reduce the risk of bleeding, all of us use strategies to minimize the impact of delayed bleeding, especially in high-risk patients. And we try to complete the clip closure, to coagulate the visible vessels. Sometimes we combine different approaches, or we can use coverage agents. Next question we have, so if we have decided to use a coverage agents, is which requirements or which properties we need for a coverage agent. The most important is the adhesion capacity and also the refractory to bacterial degradation at the pH degradation, and also to be very easy to apply. Here we have an unmet need because in all endoscopy units we have needles, we have spray catheters, but to apply these hydrogels, they are more dense, difficult to apply with these devices. In the old times, we used inspired Fogarty balloons, double lumen, to apply these hydrogels, but today we need specific devices to apply them easily, and ideally with a Luer lock connection to apply with no problems. Next question is which agents we have. To my knowledge, we have clinical evidence with these three agents, with Purastat, with modified cyanoacrylate glue, and with platel-rich plasma or PRP. Purastat is the agent we have more experience, and as you know, it's a synthetic self-assembling peptide hemostatic gel. And to my knowledge, there are only 3 single-arm interventional case series published with around 100 patients and lesions around 40 millimeters, most of them in colon. And the efficacy to prevent delayed bleeding varies from 0% till 11%, with a mean rate around 5%. It's evident we need more publication to take valid conclusion, and I think there are ongoing new observational studies with bigger sample size, I think in UK and in Spain. Perhaps the audience or the speakers have more information about the efficacy, but because with larger size, we can have more data or more solid data. In this, if we have a look at the largest case series we have with Purastat, the published case series we have in 3 different locations, esophagus, duodenum, and colon, we can identify different scenarios. And the authors found a low efficacy in duodenum, perhaps due to the influence of the pH or the acid secretion, and also in very large lesions, higher than 50 millimeters in rectum. Perhaps in this situation, we have to think in other options, and why not a combination of mechanical hydrogels applications. In this slide, you can view some endoscopic images about EMR lesions in colon, how is the scar, and how is the catheter. I'm going to how we apply the hydrogel. In this video, I show you the standard mucosal defect. This is a proximal lesion in colon. And after the resection, we introduce the catheter and we apply the Purastat. More or less, we require 3 milliliters to complete cover the total surface of this mucosal defect. It's very important we retrieve the liquid to facilitate the adhesion. And then step by step, you can easily cover all the surface. With this video, you can understand to apply coverage agents is easier than to close the scar with clips. Perhaps this is depending on the expertise, the efficiency of the clip closure is different. So, but using try to cover the mucosal defect with a hydrogel seems easier. The other two agents we have is, with the other two agents, that cyanoacrylate and PRP, we have less experience. Cyanoacrylate has been used in this single publication. That is a 2-arm interventional case series with 30 patients, 15 patients in each group. They compare cyanoacrylate versus nothing in lesions located in sigmoid colon around 30 millimeters. And the authors found a 0% of delayed bleeding in the cyanoacrylate group versus 13% in the control group. Perhaps this is a too higher bleeding rate in the control group. So, but this is a small case series. Unfortunately, I cannot provide images from the cyanoacrylate because it was not available in the publication. I had no personal experience. By contrast, with PRP, I have personal experience in the old times with 4 patients with very large lesion in rectum, and with Purastat, I found low efficacy because 1 out of the 4 patients present bleeding. With PRP, we can obtain PRP from the blood, from the patient. With 20 milliliters of blood, you can obtain till 8 to 10 milliliters of PRP. You can administer with a needle or with a spray catheter. The problem is too liquid. The liquid and the platelet needs the activation, the alpha granules, where they are in contact with the collagenous, with the muscular layer of the submucosa, they activate the platelets and then start the gelification. If you compare this video with the other, you make sense the gelification is important, the density to facilitate the coverage, because here the gravity is an important unmet need. You can view in the inferior part, is how can start the gelification over the lesion, and then step by step, you can cover the total surface with platelet-rich plasma. Based on the prior slides, we have to answer the question, when should we use coverage agents? With the current evidence, we have many questions, and this is an open debate. We have to define which are the best candidates. Exist best candidates depending on your results, depending on the expected, perhaps can we make difference depending on the technique? Is different ESD, EMR, en bloc, piecemeal resection, underwater, cold resection, or exist better location? I think patient recommendation should be based on bleeding risk and personal circumstances, but I think I can recommend their use in patients at high risk of bleeding and in cases with incomplete or low efficacy clip closure, or if you think the cost is too high, etc. But it's for that, and I agree with Heiko, we have to focus on the efficiency ratio, because perhaps it's different the cost of the adverse event, the expected rate of bleeding, and which is the cost of the preventive measure you are using. And you can debate in the discussion. Finally, other question we can have is, which are the future approaches to increase the efficacy? I think there are 3 options. One option is to use a submucosal injection of new solution or different solution with better rheological properties that can protect the thermal injury, they can protect the muscle, and after you inject the solution, you resect the lesion and the seal remain adhered to the muscle. With this, there are preclinical studies and some clinical evidence with PRP. Other option is to use new developed hydrogels, specifically designed to prevent delayed bleeding or delayed perforation with strong healing properties and refractory to bacterial degradation. There are not yet available, but probably they will consume. And finally, why not a combined approach? And because sometimes you have an incomplete clip closure, or it's difficult to obtain a complete clip closure, you can combine clips with hydrogels. A question is how many clips? And and cover the rest of the surface with hydrogels. So in conclusion, I think the coverage agents is a very promising method to prevent delayed bleeding at high risk, in patients at high risk of bleeding, but there is a lack of randomized clinical trials and head-to-head comparative studies between the different shielding products or combination with different mechanical closure methods. It's important to consider the cost effectiveness of each therapy. A part of the efficacy mucosal healing activity is another important issue to consider. And the ideal coverage agent should have a strong and important adhesion capacity to avoid migration and refractoriness to bacterial degradation and resistance to acid. Thank you very much for your attention.
Thank you, Vicente, for your excellent presentation, really technical. I have a comment because Professor Bandari gave me some data about his Purastat study in UK, and they have seen a reduction of delayed bleeding in EMR of at least 4%, so an absolute risk reduction. It means that in a cohort of around 200 patients, applying Purastat in all the patients, they have seen only 2 bleedings instead of having an estimated risk of around 6, he told me. And in ESD, it's almost the same. And also we are looking at ESD and the rates of delayed bleeding in our Spanish and French cohort. Adding all the cohort we have, we are gathering 5,000 patients. The delayed bleeding rate is around 7%. So maybe delayed bleeding after ESD is also an issue for the future. I have a curiosity because you have shown a slide with the Spanish product that I know a little. Could you tell us which is the state of this product? And I also have the curiosity because I know that Purastat remains in place around 6 days, and are residual more days. But do you know which is the longest duration of the new product in the colon?
See, the new product, the coverage gel remains adhered at least 72 hours, at least 3 days. The problem is still we have preclinical data, not clinical data, but during the evidence is strong healing properties and strong adherence remained adhered a long time.
Okay, good luck with the product. So in the audience, people are asking about tips and tricks to optimize the application of Purastat. If you have to put Purastat in all the right side columns, if you can close with clips. Okay, I can say that you have to remove the liquids, as Vicente said, and also you have to use the gravity as much as possible. And also a good trick is that to train a little your assistant to put the product drop by drop. So this way you can cover a bigger surface with a small amount of product. Okay. Any other comment, Vicente, about the clips talk of Heiko?
Oh yes. Oh, Heiko. For me, it's very interesting presentation. Congratulations, Heiko. I have some questions. So regarding the type of clips, I also have the same question. So when you have a large mucosal defect, you use a single large clip and combine with a standard clip, or use standard clips, so all large clips? Is important this to combine or not?
Yeah, we have the anchor clip and the suturing system available, and we are not formally studying this right now. So it's really a matter of preference in the moment, what seems to be the better approach. So let's say if I have a very large defect in the right colon, and I just use the suturing system because you can close those easily, and then just close the rest of it with the center clips. But I'm less experienced with the anchoring tip, which I've been using now maybe for 6 months. And so I'm still learning of how it works and how that in what situation it's good and not so good. But I had, in general, good experience with that. So I would use it in the same way, approximate the distant margin, and then close the rest with smaller clips, or use 2 of those anchoring clips. So.
And what do you think, Heiko, about the combination approach? Because how many clips is too much? Because sometimes, because sometimes I think when I apply too many clips, I increase the wall tension, and perhaps some clips can be retrieved accidentally, and this is the explanation of the bleeding when you try to. So perhaps 1 or 2 is because sometimes when you try to apply one of them in the margin when they used to bleed is enough, and then you can combine. Do you think could be a nice approach, or you are a strong believer of mechanical closure, suturing, or clips?
I do think that you need to close the entire defect as best as you can. That's why the definition, that I proposed or that I quoted from Rex, I'm not so happy with this, and others use other definitions, but it's hard to really say what it is, right? So I don't think you should see really any submucosa. I think the clips should be really kind of go deep into the submucosa. So when you kind of, before it closes, you want to suction so that the tissue gets into it, and then you deploy it. So I'm really curious about larger studies on the suturing system, which does not do it. It just covers it. And your idea about bacterial, contribution maybe to the healing effect or non-healing, and maybe they have some role in the bleeding risk. So if you close it, maybe that already protects the whole thing and promotes healing, and you don't have to have the submucosal closure. So yeah, but in general, I think I want to close the entire thing, and I use clips, not abundantly, but I use it until it's close that I don't see any submucosa anymore. So I've seen people using more clips than I have, but I have used also.
Okay, Heiko, it's true that our score didn't fit in your study, but at the end, in your conclusions, you summarize telling that we have to individualize the risk in the patients, but it's size, right side, anticoagulants, and comorbidities maybe. So it's all the score is on that. No, I don't sum the score, but I believe in risk of the patients. But don't you think that too many studies and even real cases fail because we don't consider all these aspects in the patients? What do you think? Tell us to the audience your thoughts.
I think it's it's like medicine. So a patient is an individual, and they have their different risk of depending on what the polyp is and what you do to it and what the patient brings him or herself to the whole thing. Eventually, I guess we have some kind of idea to have some kind of calculation or something in our minds to say, okay, it's the best approach for this lesion. Let's say it's a regular sessile serrated polyp appearance. You take it off cold, no way to clip this. Okay. There's like hardly any risk of bleeding. It's a bulky adenomatous polyp in the right colon, maybe even in the cecum, which has the highest bleeding risk to begin with. And the patient on anticoagulation, I do my very best thing to close it as close as I can. And there was a question about distance to the hospital, may even keep that patient in the hospital or something like that. So it depends really on what the situation is. Then the question is really more, what about like the patient who's in antithrombotics, when you do it in the left colon, and do you close it after 4 centimeter? So I don't think it would make it into your risk score because because it doesn't get to the very high risk score. But I don't think we have the clear answers because randomized trials only have 2. You have one group and the other. You don't have the individual one. So maybe machine learning AI might assist us in this situation.
Yeah, to me, a good closure works in every location. to me, even if the studies don't say the same. You know, it's a good mechanical closure was everywhere, but probably not all the closures resist. So this is another this is another thing. Don't you think also that we have a lot of ESG courses, gastroenterology, anastomosis courses, and whatever, and we don't have basic courses in endoscopy, teaching fellows and younger colleagues in basic things like put a clip, a standard clip? And you think that the societies must do something on that? Societies or brands?
You're asking whether we should do more in terms of how to teach our fellows?
Yeah. In basic things like hemostasis and using clips.
Oh, definitely. I think it's a skill as other skills, and we should do our best to teach this. I mean, it's one of the major tools that we have for acute bleeding situations or prevention or closure of defects in general. So, but Vicente, I'm gonna have you also respond.
Yes, I think because with clips, this is an interesting, a very crucial point, because with clips, sometimes you obtain heterogeneous results because the expertise is very important. The proper technique is quite important because it's quite different. If you are a junior endoscopist, perhaps your results is much more different if you are a senior endoscopist. So I think you have to take this in mind. Perhaps it's heterogeneous, or how is your clipping technique? So perhaps we have to teach the curriculum is quite important, and it's for that. So I think we have to give the opportunity the coverage agents, so because to obtain homogeneous results is for that. If you are an expert, you can obtain a very proper closure, mechanical closure, but if you are not so expert, or if the coverage is cheap, perhaps covered all lesions could be a good option. But it's evident we need more data. So because from a green perspective, because at the end clips is not green, many clips is not green, but it's an open debate.
I mean, maybe the ideal intervention or prevention would be something simple that everyone can do and doesn't cost much. But like a covering agent, seems like it could be a simple approach, right? If it's working, you know, it may not require the technical skill that is needed for a clip closure. And then the cost in general, you know, financial or environment, if the cost in general would be really low, we might be fine to do it in the left colon or anywhere, because even if it doesn't benefit 100, maybe it benefits just 1. But that kind of balance has to be considered always.
Yeah, I also like it a lot, your slide about the cost and the vision of the patient and the economy, because to me the center of our care is the patient. So it's true that we have published on cost-effective studies, blah blah. But at the end, the patient, even us, if we go for a coronary resection, we want zero risk or the minimum risk as possible. So we have to take this in mind, no, for every patient that we treat. So it's so this is another question. What do you think about that? What do you achieve for your patients?
I mean,
what do you want?
I keep that in mind. So I mean, there was a question about if the patient lives far away, and I work in a rural area, so some patients travel 2-3 hours, and then I keep that in mind. You know, do I keep the patient overnight? Do I clip? But I have to say, Eduardo, I'm very data driven in some ways. So for instance, we also noticed that many patients still bleed even after they were closed, like in the study. So it's not 100% solution.
Yeah, no.
So, but for instance, for cold snare resection, which I'm increasingly have done, I don't close any of these defects. And we will present some results of our study at DW, but the results kind of support that approach. Let's put it this way.
yeah, it's not one answer for all the questions. Some people in the audience are asking when it's safe to administer anticoagulation medication after an EMR. So okay, it's very difficult. It's impossible to address with science this question, but it's better a bleeding than a stroke. This is something that I can tell to the audience. So depending of the size of your resection, if it's not massive, it's better to introduce the anticoagulation as soon as possible. In the Spanish Society, in the EMR ESGE third space group, there are 2 studies running trying to address this question in polyps till 2 centimeters. If it's safe to remove it, even maintaining the anticoagulation. So probably the answer is as soon as possible. What do you think? What is your approach in your hospitals, Vicente and Heiko?
I agree with you, Eduardo. If your patient have a high risk of a stroke, you have to reintroduce the medication as early as you can. And here is very important to clip closure. If you have performed a very important clip closure, you can reintroduce the anticoagulant earlier. So that yes, it's not clear rules, but the risk of a stroke is higher than the risk of bleeding, I think. So earlier reintroduction makes sense.
Yeah, I generally agree with this approach. The sooner the better. We have a different algorithm now in our hospital where we don't, for a general patient who comes for a colonoscopy, we don't hold anticoagulation anymore, except for like similar to the ESGE guidelines. We only hold the DUEX the morning of the procedure, but Coumadin or warfarin we don't stop. And so I take off any polyp cold that are approachable with cold snare resection on anticoagulation. I haven't had any problems so far. So, but if I know it's a hot EMR, I would of course stop it and then reintroduce as soon as possible. And usually, which is like about 2 days thereafter, I also look at the risk score of thromboembolic event, when to start it. If there's a really high risk, which I would consider 5 or higher on the CHAT score, then I wait about 5 days before reintroducing like DUEX. But no, I'm sorry. If it's less than 5, if it's less than 5, anyway, I wait 5 days. So the higher the risk of thromboembolic event, the sooner I start it.
Okay. I'm looking to the questions from the audience. Is there any benefit of using Purastat after endoscopic ampulectomy to reduce the risk of delayed bleeding? Okay, probably there is no evidence about that, but it's anesthetic, so it's.
No, I think in this case, when I used to perform ampulectomy, so to reduce the risk of bleeding, at least in not so big, I try to inject saline in the distal margin to reduce the risk of bleeding and the risk of perforation. But I think I have no experience with Purastat in this situation.
I've used it to prevent or to stop the sphincterotomy bleeding, and it works. And there is a Japanese study that there is less complications applying Purastat than with injection of epinephrine. But I haven't heard any big study about ampulectomy.
No.
If it's an hemostatic, probably it works, but I don't know.
Yeah.
Any question, Heiko, that you want to address after the webinar?
No, I think
many things are.
I mean, we can talk about this for a long time, I think.
Yeah.
So.
Yeah, now it's true that we have a lot of solutions, and all the studies were done with 11 clips, but now the armamentarium is increasing, and we are lucky to also. Also, there was a question about which vessels we have to treat in the mucosal defect. You know, one concept that I have seen in a Chinese paper that is not seen in the Australian paper is the conception of cut vessels. When we see a vessel really cut, the surface is cut, and I think that this is one source of bleeding, and we have, if possible, we have to coagulate that. And I've seen almost immediate bleedings after ESD due to this kind of vessels. And this is probably a new concept that we can introduce for artificial intelligence studies also. Okay, so maybe it's time to close the webinar. So I would like to thank you, Heiko and Professor Heiko Pohl, Professor Vicente Lorenzo-Zúñiga. Thank you to the organizer, ESGE, David Inker, Gabriela Parca. This year is the 60th anniversary of ESGE, and there is some activities this year. Also, you will be really welcome in the ESG days in Berlin. It's going to be a really nice venue. The society welcome to everybody who can to join. Also, to be a member of ESG has a lot of benefits. A lot of European societies have also the dual member possibility to be member of your society and to be member of the ESG, and there are some discounts. The ESG fellowship grants are open to applications, so it's a good option if you want to be trained in any kind of complex technique. And we invite you to the next webinar about the US guide, the gastroenterostomy, with Professor Mark Baghdad and Professor Perez Miranda, and the chair is Professor Zach van der Merwe, that you are invited to join us in February 28th. And that's all. Thank you for that. Thank you for this evening. See you soon in person, I hope.
Yeah, take care.
See you. Take care.
Bye.
Good to see you.
Bye-bye.